Hello, good afternoon, everyone. Welcome to the Independent Sage briefing. Now, as many of you know, around the UK, testing and other COVID monitoring measures are being wound down. England's already stopped free testing for the majority. Scotland, Northern Ireland, and Wales will soon follow suit. And the results of paid for tests cannot be reported on the government portal. At the same time, funding for COVID surveillance projects like the REACT study out of Imperial, the Zoe COVID app out of King's, which tracks people's symptoms, they've both been withdrawn, which begs the question, how on earth are we supposed to keep track of infections? Yes, hospitalizations are coming down, deaths may have peaked, but we still have millions of people being exposed to the virus. And with surveillance systems going, we have no real way of tracking it, nor of understanding the evolution or being able to react quickly to new outbreaks. So to help us discuss this issue today, we've got three brilliant guests who will share their expertise. From Oxford, Dr Katrina Lythgoe, an expert on evolution of viruses, Professor Ravindra Gupta from Cambridge, who's an expert in virus infection and immunity, and Dr Daniel Goyal, who's a consultant physician from the Highlands. But before I call on our own Professor Aris Katzourakis from Oxford to host the session, I'm going to turn to our new member of Independent Sage, Dr. Duncan Robertson, who will take us through the numbers and trends. He's a policy and strategy analytics academic at Loughborough University and a fellow of St Catherine's College, Oxford. So over to you, Duncan.
Thank you very much, Anthony. So we're going to be looking at the data today, and I think it's kind of interesting when we think about where we get the data from, particularly for infections, because as Anthony was saying, the number of people who can actually report their cases is now very low. So we have to rely on things like the ONS survey, the infection survey. So I'm going to be talking about that. So I'm going to talk about hospitalizations and a little bit on the pressure on the health system. And then talking about vaccinations, we have some new data on vaccinations for 5 to 11-year-olds. And then just to talk about the information we have on variants going forward. So let's go through that. So on infections, we rely on the ONS survey now. And as we can see, if we split it down into the different nations of the UK, all seem to be falling, perhaps apart from Northern Ireland. So this is a good sign in terms of perhaps this Omicron wave, it has peaked and is now declining. So that's all very good news. So in terms of the numbers, we have roughly 6% of people who would test positive in Wales and around 4% of people who would test positive in England, Scotland, and Northern Ireland. So this is a slide of actually who those people would be. So this is going from left to right, is from the beginning of this year up to now, and then splitting it down into each of those rows is a different age group. And I'll just put the monochrome version, it's the same data. So we have essentially on that top row, we have primary school children. The second row, we have secondary school children, and then young adults going up to over 70s on the bottom row. And I think, if we look at last week compared to this week, so they're the final two columns, we can see in every age group, the prevalence is declining. So this is very good news. And, to compare it in terms of where we were in January, when we had these huge numbers of people, particularly in primary school ages, who were infected. So good news. In terms of where they are, we can see that actually we're starting to decline in London, Birmingham, Manchester. So the sort of major conurbations seem to be declining first. So with the rest of the country catching up. And in terms of, number of people admitted to hospital, this is just data for England. So this is good news as well. The number admitted per day is decreasing. But of course, as well as the number of people going in every day, you have the number of people actually in hospital. That also is declining. So good news, but you can see as each of these variants from about June last year, they may come in waves, but you still have the number of people in hospital kind of increases. So it takes a long time for those people who have been in hospital to clear out, but hopefully that will decline in the weeks ahead. One thing to note is we still have more than 1,000 deaths per week involving COVID-19. So it's a relatively high number. So it's not as though COVID is over by any means. And one thing that I think is kind of interesting about the pressure on the health system is what's happening to ambulance data. So we have data on what are called C1, Category 1 and Category 2 ambulance response times. And this is from before the pandemic to, right up to where we are now. So, so Category 1 is the blue at the bottom, and that seems to be increasing steadily. So up to about getting just under 10 minutes for the average response time in England, but I think you can see it more closely on the Category 2. So there, Category 1 is life-threatening. Category 2 is, for example, stroke or chest pain symptoms where you need a fast response. And that seems to be increasing kind of significantly. So you can see over an hour is the average response time for an ambulance in England for those Category 2 cases. So on to vaccinations. We can see these are the percentage of people who have had vaccinations. We still have, a number of people who haven't been vaccinated, but roughly most people have had their autumn booster as a population. But the number of people getting those vaccinations is relatively low per day. And of course, it's concentrating on two groups, the younger 5 to 11-year-olds who are now eligible, and the spring booster campaign for the most vulnerable. And if we look at the booster campaign, we can see it's actually doing pretty well in terms of over 75s. We have more than half of the over 75s who've had their spring booster, giving them hopefully more protection in the months to come. But in terms of severely immunocompromised individuals, in terms of their boosters, we have less than half who've had their spring booster. So they're still, that still perhaps needs some work over the months and weeks ahead. This is a chart of who's been vaccinated ever since the beginning of the vaccination programme. And the line on the bottom right, that grey line you can see is 5 to 11-year-olds who have been eligible for since roughly the beginning of April for their vaccinations, their first vaccinations. And you can see what happens with these charts is it kind of slowly go along and then they suddenly take off. And that's where mass vaccinations and that is eligible. So for the 5 to 11-year-olds, they're taking off relatively slowly, which, may be reasons for that. Some people may have had, some of these children may have been infected and need to wait 12 weeks to get a vaccination. But it's still relatively slow for that age group. And I think these are the figures of 5 to 11-year-olds who have been vaccinated. So only 5% in England compared to 16% in Scotland of 5 to 11-year-olds have been vaccinated. So still some work to go there. And finally, just talking about variants, because this is a session on surveillance, we have had an excellent programme of looking at the variants, sequencing the cases. This is what we have at the moment. So almost all of the cases that are being sequenced at the moment are BA2, so one of the Omicron variants, which is, so we're kind of almost waiting for the next variant to come along, but at the moment we have Omicron is very much dominant. And this is the sort of data we have been looking at. So from Sanger, part of the Wellcome Institute, we've had, what they do is they estimate the number of people the number of cases based on the ONS survey, and then split them according to the percentage of sequences they have. So we can see the number of cases for Omicron there at the end. And also for COG UK as a whole, we can see, BA2, that like kind of grayish colour, beige, I don't know what you call that colour, but the browny colour at the end. But you can see potentially the number of sequences as a whole is decreasing, which is of course a concern, and that's what we'll be talking about for the rest of the session. So that's the end of the data for this week.
Duncan, thank you. That's fascinating data. I'm rather shocked that 95% of 5 to 11-year-olds have not been vaccinated. And the ambulance response time is interesting. I wonder how much that is due to staff absences as well from people off work with the virus. But anyway, we're going to move on, and I'm going to hand over to Aris to introduce this discussion on surveillance, or the lack of it, and what it means, and various other things. So over to you, Aris.
Sure, thanks. Yeah, so I mean, when we think about the response to COVID and the scientific basis and the deployment, the first thing a lot of people think about is the vaccination program, which was an incredible success. It was very, very quick for development and deployment, and a lot of people have now been successfully vaccinated. Another slightly less visible aspect to the response, both in terms of the science but also the logistics, is of course surveillance, and that has also been an incredibly well-resourced and successful program. There have been a number of initiatives, and Duncan has mentioned a few already. ONS, COG UK, we have REACT, UKHSA, the Sanger, and all sorts of other initiatives that deal in various different types of surveillance. So I'd like to focus a bit now on what we've learned from surveillance, including in particular what it's told us about virus evolution, which is an area that I have a particular interest in, but also lessons more generally regarding the management of the pandemic. So here in the UK, we've experienced several waves during this pandemic, and some, but not all of these waves, can be mapped back to the emergence of particular variants of concern. So talking about these variants of concern and how they've influenced the dynamics of the pandemic, I'd like to turn to Katrina Lythgoe, also at Oxford here at the Big Data Institute first, and ask, what have you felt has been the role of sequence surveillance in understanding the dynamics of the different waves of the pandemic?
Yeah, thank you. Thank you very much, Aris. I mean, fundamentally, the sequencing is really what's most vital to understanding the evolutionary landscape of the virus, as you've been saying. So if we can take a case in point, back towards the end of 2020, we were starting to see an uptick in infections. And it was through the surveillance that that alpha variant was identified. We saw that it had a huge number of mutations, and that it was this new variant that was responsible for the uptick in infections, and therefore this can then translate into policy decisions when people are trying to make decisions about what to make in response. And then subsequently, of course, we've seen these new variants of concern emerging, which have then themselves been associated with these new upticks in infection. Okay,
so at the same time, so we've seen these variants emerging, and they've coincided with these different waves, like the Alpha and the Delta variants, and now, of course, the Omicron variants. At the same time as figuring out the dynamics and the sequence evolution, we've also used this data in order to gain a better understanding of the biology of the virus. So in this respect, I'll turn to Professor Gupta, who's just joined us, and ask, how do you feel this surveillance work has been matched with an increased understanding in the biology of this virus? How has our understanding of this virus and its biology changed over the course of the pandemic?
Thanks very much. I think there was some early work, back in early 2020, where people like Jesse Bloom were using high throughput screening technology to understand the impact of each mutation and spike sequentially, and that laid some of the foundations for understanding the mutations that were arising. But of course, we had to see them in real viruses that were really transmitting to understand their true biological significance. And of course, we noted that the first few variants, alpha, beta, gamma, had the N501Y mutation, and a couple of them had other spike receptor binding domain changes that suggested that they were immune escape variants, and neutralizing antibodies were potentially what they were running away from. So that sort of was an early indication. But the things we didn't understand so well were things like transmissibility and how infectious the virus was. So either within a host or even between hosts. And I still think we don't really have a handle on between host transmission potentially and how it relates to intra-host sort of replication. But certainly, as we've gone on with the variants, we've started understanding not only what the neutralizing antibody escape mutations are, but of course there are a large number of mutations that increase virus fitness or in infectivity. Many of them are in the spike protein, but some are to do with increasing the number of genome copies, for example. And so our understanding is actually being improved by watching what the virus is doing. And so, of course, this isn't really a great way of understanding the biology of virus in terms of waiting for it to do things, but it's been hard to study and otherwise. But I think it's been very illuminating. But I don't think we're at the sort of stage where we can look at a set of mutations and kind of predict exactly what the virus is going to do, and that's a big problem at the moment.
Okay. So at the same time as understanding the virus, so we've got these different waves and these different variants emerging with distinct biological properties. At the same time, on the other side of the virus, we have the patients and we have what's going on in the healthcare system and the hospitals. So I'd like to bring in Dr. Goyal at this point and ask, how have these different waves with their distinct characteristics been experienced from a clinical side? So from the perspective of the NHS.
Thanks, Aris. Yes, it's been quite some roller coaster of a ride. The kind of one you regret getting on at the start, terrifying at times. Particularly the first wave. I remember, the visible relief in the team as patients turned the corner and improved, which is quite an unusual thing in medicine. Most things we manage and we expect people to improve. For COVID, that was very different. Then Alpha came, we were using steroids more, we had a bit of hope, we were doing a bit better. People were presenting a little bit earlier, which was helpful, but still it was a huge moment of relief as we saw the patients improve and recover. Delta then challenged us further. I think the surveillance programs and the testing and understanding the different presentations of COVID was hugely helpful to us. We knew about silent hypoxia. We knew that people could present with a sore throat and feel a bit groggy and a bit fatigued and actually be hypoxic. And this widespread testing that was in place at the time was hugely helpful. We saw people earlier. We were able to put treatment in sooner. And able to get them out of the hospital with less disability and morbidity. But still, with Delta pre-vaccine, it was a moment of relief when they got better. And then the vaccines came, and it was an absolute game changer for us. We are now, it's our first question to a COVID patient: how many vaccines have you had? And if they say, they're unvaccinated, we're back to the start. We're back to March 2020. We're very worried. We're on tenterhooks to see if they'll turn the corner. But if they say they're vaccinated, it puts them in a different category altogether. So now we're surprised if someone doesn't respond to treatment. That's vulnerable. That's the elderly as well. We would be surprised if they don't make it through. I have to say, Aris, of late, I'm starting to be a wee bit more concerned. I think I'm seeing people presenting with a bit more chest symptoms, a bit more pneumonitis cases, particularly in younger and middle-aged people. They think they can ride it out at home. They think it's normal to feel, excuse me, I'm so sorry. They think it's normal to feel severely fatigued with COVID and therefore don't bother getting help. And I think that's the danger with the flu comparison to COVID. Often these people have pneumonitis, they are hypoxic, we can treat them, we can help them, and we can certainly reduce the impact of long COVID going forward. So yeah, it's a roller coaster, Aris, and I want to get off pretty soon if that's possible.
So the vaccines, like you say, they've been transformational to patient management, right, and to the number of people that we're having to deal with. One of the hopes with surveillance is that we may use the sequence information, our understanding of the biology of the virus, to inform the vaccination program moving forwards and to refine and improve the vaccines. So I'd like to turn back to Professor Gupta here and say, like, are we at the point now that the data might suggest we need to be thinking about updating our vaccines, and how is that sort of progressing? And are we at the point now where we should be thinking of updated vaccines?
Yeah, that's the big question. I'm not sure. I'd say that I don't think we're there yet with understanding which virus we need to be using if we're going to update the vaccine, because of course, although we've got a sort of spate of different Omicron sublineages expanding and contracting at various rates in different parts of the world, it's unclear whether an Omicron-specific vaccine will be ready in time, and secondly, whether it'll be effective against future variants, because of course, many, very high proportions of us have already been exposed to Omicron with some degree of cross-reactivity with other subvariants, sublineages. So, and if you look at the sort of antigenic landscapes that have been made, which are these sort of maps of different variants in sort of space, depending on how far away they are from Wuhan 1, in terms of their antibody escape properties, the variants we've seen are kind of sort of clustered all around the Wuhan 1 virus. So if you were going to use another virus, it would be hard to pick which one. The other alternative, of course, is to put multiple viruses in to a multivalent vaccine, and that's one other option. But at the moment, I think, for me, pan-coronavirus vaccine, attempts are probably where I would spend most of my time, because, going for conserved parts of the virus, parts of the virus that are not changing, and yet are immunogenic, will be the key. But of course, that's a much more difficult technical problem to solve.
Okay. Now, as we've been dealing with Omicron and its emergence, and trying to think a little bit about how it came about, what it's doing, and what it might tell us about the future, one of the things that's received a lot of attention is this idea, this hypothesis that this virus might have emerged in particular types of patients, so chronically infected or certain kinds of immunocompromised patients. I was wondering if anyone had any thoughts about that idea, and how likely it is to be determining the emergence of this particular lineage and potentially future lineages.
I mean, I can speak to that, because I think we reported one of the first sort of cases of tracking chronic infection in people, or in an individual in this case who had immune suppression, was on a treatment that blocked antibodies, essentially, or blocked their production. And so the patient ended up with a long-term infection with coronavirus that was became severe, then it waned, and then it became worse. And that's interesting in itself. And it was treated with a number of things, including convalescent plasma. And when that happened, the virus was not cleared. But when we did sequencing of the virus, we found that the virus was changing really dramatically in many different places and changing over time. When we studied the mutations, we made these mutations in artificial viruses that correspond to SARS-CoV-2, and we found that some of them were helping the virus escape immunity and antibodies, and one of them was helping the virus get more fit and replicate faster. So this is the sort of blueprint for what's happening out there, because these same mutations are being seen in all the new VOX, and the fact that the VOX come out of nowhere, in other words, you can't really see their ancestors very easily, and their closest relatives are very early viruses. For example, Omicron's closest relative appears to be a sort of B1 lineage, in other words, a virus that was circulating in 2020. So this is a further evidence that it's happening in individuals, that gives a chance to the virus to kind of grow and learn to overcome our defenses. So that's the most plausible explanation for what's going on. And then, of course, there's the HIV epidemic in sub-Saharan Africa, where this is a cause of immune suppression in many people, and a couple of the variants have been identified first in South Africa, the place with the highest prevalence of HIV in the world, and they've shown chronic infection with lots of mutations emerging in an individual chronically infected there. So there are some, a few strands of evidence that pulled together leave no doubt in my mind as to where these variants are coming from.
I mean, I think a lot of people agree that that's a very, very sort of plausible hypothesis for Omicron and other VOX variants of concern. I mean, if it's the case, can we use this knowledge in any way to mitigate against the potential emergence of future variants? Is there anything we can do to sort of stop the likelihood of these kind of things happening again? Happy for anyone to jump in if.
It's a tall order because we have drugs. Sorry, were you going to say something, Dan? Go ahead.
No, I think I was going to say the same line as you, that maybe proactive management of COVID cases would be useful. I think identifying those, which comes back to the testing and surveillance thing. Again, if we stay on top of them, we catch them early enough, one would hope that the antiviral treatments would reduce the viral burden and therefore reduce the chances of mutation, I guess. That's me with my bias of wanting people with COVID to have clinical care as well, of course.
Yeah, and so antivirals, for example, are available, and we have monoclonals and things for prophylaxis. But of course, this, if we think that HIV and may be a source, and communities that are marginalized being potential places where this might happen, then getting those treatments and access to those is going to be incredibly difficult. Of course, reducing the total number of infections and the burden of disease globally will in turn be beneficial in this respect. But of course, we're struggling with that as the variants. We've sort of found ourselves in a sort of vicious cycle of fitter and fitter variants with more and more immune escape, and that's going to be hard to overcome, I think.
So speaking of immune escape, I mean, one of the really unusual features of Omicron, at least compared to the original strain that we had, is this tendency or capacity for Omicron to be responsible for reinfections. So we're hearing more and more instances of people who've had COVID getting COVID again, sometimes getting COVID again within a relatively narrow period of time, right? Not necessarily a whole year, but maybe a couple of months. And so I mean, in this respect, turning to Katrina Lythgoe again. So what have we learned in this respect? Has the surveillance data sort of told us anything interesting regarding the reinfections and how much they should worry us?
Yeah, I mean, the genome, the genomics specifically in this are really important because without the genomics, it's very difficult to tell what's a long infection. And we know that some people tend to have long infections that bumble along versus reinfections. And so particularly when we've got different variants, it's very easily to tell apart whether it's the same infection or a different infection if it's with a different variant. What's much harder is to tell those apart when it's the same variant. So when somebody tests positive multiple times, is this actually the same infection that's maybe reemerged, or is this a reinfection? And that's a very difficult question to answer. But yeah, it's very clear from the data that people are getting reinfected multiple times with different variants, for sure.
And do we know anything about? Again, this is an open question to anyone, right? But we hear a lot of the time people say, oh, my first bout was not so bad, the second bout was worse, or my first bout was really bad, the second bout was nothing, or they were both just as bad as each other, and that sort of thing. Do we have any information at all about the likelihood of a second bout of COVID being more or less severe than a first, or is it a completely open question? I'm seeing a hand up from Deepti.
I think there's some data on this in adults, but it differs so much by variant. I mean, with Omicron, for example, past infection does confer some protection against infection, but much more protection against severe disease, but, and again, when you look at reinfection, when you look at past infection and vaccination, that also paints a different picture, something that we don't fully understand. And I think then there's a risk of long COVID with reinfection, which is something that we almost know nothing about, which is why surveillance efforts are very, very important. What we know anecdotally is that people do get long COVID even after their second infection, but whether they get it less or more is something that we don't really know. And I want to highlight that given reinfections, we're seeing early reinfections are more common in children. We particularly need to understand this in the context of children. I mean, there are, for example, reports that show that the hospitalization rate for reinfection children is the same as for the first infection, but these haven't been corrected for many things like the type of variant. So we need to understand the sort of protection past infection confers in much more detail, not just in terms of infection, but also hospitalization and long COVID for all age groups, including children who are much more prone to reinfection.
Okay, and hand up from Christina Pagel.
Yeah, I just wanted to add to what Dixie was saying, that actually that's where some surveillance like the ONS infection survey could be incredibly powerful in looking at the issue of reinfection, because they have been tracking people now for almost 2 years, or actually over 2 years. And so there you could imagine that the ONS could have and will have data increasingly on reinfection severity, symptoms, and hospitalization and long COVID that I hope that they will be looking at and publishing on over the next few months and years.
Yeah, I mean, thinking about the kind of data that will may be produced over the coming months, potentially years, what do people think are the sort of big questions that we need to answer in the next sort of 6 months using surveillance data? I mean, obviously, reinfection, the severity of reinfections is a really big one. Do people have any thoughts about what we'd really need to get data on over the coming months and have sort of concrete answers to?
I mean, I'd say that's the key question, is looking, as Christina said, is looking at particularly these people who have been followed for a long period of time to really understand what the patterns of reinfections are, what the patterns are of waning immunity, just so we can then try and understand kind of what the future may look like. I think for sure that's the biggest question. And then, of course, with the ONS, it's not only a study where it's looking at people longitudinally through time, but it's also a household-based study, which again is also really really important, because then you can start to look at transmissions in the household and, for example, secondary attack rates, and link those to the characteristics of the virus and the infections.
If I could add to that, Aris, it would be useful to try and get a picture of what burden we're going to face going forward. I think, what burden is long COVID, is repeat infections, is new variants going to put on the healthcare service, and how much do we need to expand the service? And it would be really good to have the evidence, the economic argument for that. And obviously we need that kind of testing data to do that.
So, I mean, thinking about that kind of data and looking back, has that kind of data in the past been important for planning and for sort of healthcare capacity and management?
Yes, I mean, I remember the first wave. We didn't know what was going on really, and the whole country went on lockdown in terms of, hospitals had to close routine care, and face-to-face appointments were cancelled. We had to split the teams in two, and actually, for a lot of the first wave, many hospitals were sitting with not very many COVID patients at all, and that's because we didn't know what was going on in the community. I think, as you know, the upscaling of testing was delayed. I think the government preferred private contractors to our NHS ones, and we weren't able to upscale in time. And the knock-on effect, the healthcare rationing that came on the back of that was massive, and we're still feeling it now. But then you fast forward to the alpha wave, and you can, you remember Manchester, Glasgow, Birmingham getting hit really hard. And actually, we had a 2-week run-in period where we knew we were going to get hit hard, and they upscaled, and they had a surge capacity, and they still got hammered hard, but it would have been a lot worse without that pre-warning that, look, in your area just now, the variants are really, the infection rates are very high. And I look at it every week in my area. I look at it every week and say, look, okay, we're struggling a bit now. and we will reopen the COVID unit, or we'll switch the COVID unit, or we'll get more nursing staff in. I think it's hugely helpful for us to prepare.
So Stephen Griffin wants to come in.
Thanks, Aris. I was just going to say another really important use for data from things like COG UK that has been used is to monitor surveillance for mutations in the virus that might confer resistance to things like monoclonal antibody therapies. We know that using those and overusing those can lead to that. We know that different variants have different susceptibilities to those. And that not only tells us if something's happening in patients, it also tells us which medicines to give to the right patients, depending on which variants that they may or may not be infected with. And I think as well as we seem to be, not suppressing cases, and there is a plan to rely heavily on antiviral therapies, these antiviral therapies that we're giving to people are being given as single agents, single drugs, and a virus that has the capability to evolve as quickly as SARS coronavirus 2 does have the potential to change to become resistant to those drugs. And as well as just becoming resistant in one person, that if they were to start becoming transmissible and fit enough to transmit between people, that's something that we will need to be critically aware of going forwards.
Definitely. I mean, coming back to the point a little bit about vaccines, I mean, I know, Professor Gupta, you talked about the sort of pan-coronavirus vaccines, but I mean, at the same time, we've heard from Moderna, I think that they're doing they're getting good results from trials of a bivalent vaccine that has Omicron and is it Omicron and Wuhan or Omicron and Delta? I can't even remember which two strains are in that one, but I mean, the idea of introducing multivalent vaccines in the autumn booster program 2022 potentially, if needed, is that something we need to be keeping on top of until sort of pan-coronavirus vaccines arrive?
Potentially, yes. I mean, I think that of course you don't know how good they're going to be until you see the future variants. Of course, you can say that they protect against disease against current variants, but we already have a vaccine that can do that. And so we could look at convergent evolution in terms of, which is basically the concept where you're seeing the same mutations coming up on different variants. You can see that certain spike mutations are coming up in Omicron that were found in Delta, for example. So you could have a panel of viruses, for example, representing the different major epitopes or the major targets of our antibodies, and kind of generating a mix of viruses based not just because they're different variants, but actually because they represent a range of different target escape mutations that we can use to immunize with. So that may be a way to go, to just generate representative VOX of different major classes of immune escape variants. They may or not work, of course. And we should also remember that vaccine breakthrough, whatever we're going to call it, is not simply a product of immune escape. And we've been talking about this for a long time, which is that infectivity is a major determinant of whether you get reinfected. If you look at people who get infected through breakthrough, their titers of antibodies and neutralization is pretty much the same, whether you get infected or not. Of course, the difference is disease progression. So immune escape in terms of disease progression is potentially more about T cells. We know that T cell escape is not that common, so it's not really in the virus's interest to be trying to escape T cell activity. But clearly, antibodies do play effect at the mucosal surface. So I think understanding a bit more about how the virus is actually working would be quite useful and going forward with these strategies.
I mean, this is a sort of slightly speculative idea, right? But I mean, one of the notions that's been floated is that potentially that the interactions between different immunogens may have shaped particular populations' immune responses, right? Like in South Africa, for example, one of the ideas is that the prior exposure to beta may have had a role in the way that that's interacted with subsequent vaccination and have given a sort of stronger protection against disease to the Omicron variants. Is that a sort of a plausible way of thinking about things and maybe mapping out the future?
I think potentially yes, but I'm not a big believer in that theory. I mean, yes, you may get better cross protection from a virus, but you imagine Delta was nearly 18 months ago, and so with the concept of waning going on, it's hard to imagine that the low titers elicited from beta will protect you from infection, number one, and number two, severe disease. But so there's no reason why beta infection will be better than an alpha infection in terms of disease progression, is there? I think that the more likely explanation for less severity and reduced severity in South Africa is probably going to be about age structure of the population, as well as prior infection plus some vaccine on top of that.
Okay. Dean and
Aris, would you allow me just to sort of ask another question of our panel?
Of course.
It's be a hard one.
But obviously this is about surveillance, and what would be the future of surveillance, and we've seen what level of surveillance has been done within the UK in terms of reporting the mass PCR testing and so on, and then of course the COG UK now UK HSA sequencing. And of course, that builds on the sort of techniques that have been used for previous surveillance. But as everything is being wound down now and cuts to UK HSA, there's a real risk that we go to last generation sequencing rather than surveillance, rather than next generation surveillance. And given that that there will be new pandemics. We already know that there's existing surveillance for other pathogens. I'd really welcome your views, Katrina, Dan, Ravi, of what are the technological advances that would allow for a next generation surveillance, which could be wider. I'm just thinking, for instance, is there a way of, on dried blood spots, which are easier to collect, less unwieldy than blood samples, and doing, large scale antibody screening epitope, based on large numbers of epitopes that can both say something about the COVID pandemic and risks for future emergence of or identifying new variants as they come through, but also, of course, a whole range of other pathogens, and the ecosystem, as we know, has been altered over the period of lockdown, as we've learned with flu. So I'd really value your views, on that.
I mean, I can speak to that first. I mean, I envision a future, whether it will be realised or not, where we do have true global genomic surveillance, and as you say, not just for SARS-CoV-2, but for other pathogens as well. And we can imagine that this will be both a diagnostic tool. So, for example, if a child goes to a clinic and they've got fever, then we know, then the clinician can know whether they've maybe got malaria or a different a viral infection. And there are methods being developed now, metagenomic methods, which should enable diagnostics through a single sample, and then that combined then with true genomic surveillance, like we see in ONS and we saw in the REACT, where people are sampled regardless of symptoms, just to see a true kind of picture of what's circulating at any moment in time. I think the two of those together kind of will be extremely powerful in the future. So I guess that's kind of my utopian future, if you like.
I like the sound of that. Anyone else want to follow up on that?
If not, Aris, we've got some public questions that I could ask that relate to some of these issues as well. Can I just start with one which I'll read out before we come to Chris? Sue Geimer wrote in to say, Denmark has suspended its vaccination program as it claims the pandemic is now, quotes, under control. Is this true? And in fact, is the failure to collect data in the UK making the ending of immunisation inevitable here? Would anyone like to answer that? Do I see any hands raised? Deep T?
Yeah, I mean, I don't know what to say to that. I mean, Denmark sort of decided a while ago that the pandemic was over, right in the middle of a massive surge, where we saw BA2 become dominant. And of course, the cases are coming down now, but we know how this works. I mean, we've seen cyclical surges as new sublineages and new variants emerge, and that will continue to happen. And I don't think you can plan to suspend your vaccination program in the hope that you won't need to vaccinate people until 3 to 4 or 5 months from now. I think, what we need to be doing, and we haven't spoken much about this in terms of variants, is actually really suppressing transmission to reduce the risk of virus evolution and also protecting vulnerable people, particularly immunocompromised people, where we've seen virus persistence for long periods of time. And I think, unless, as we keep burying our heads in the sand, I think we are going to see massive cyclical waves, which will cause mass disruption and sadly long COVID and deaths in some people, unless we actually tackle the problem head on.
Nobody told us that this could be a consideration, asymptomatic.
Oh, somebody was online. Okay.
Yeah.
Dipti, we'll go to the next question. Shall we have Chris Grimmett is going to read out a question. Chris, you're open to you.
Hi, thanks. My question is, if you're triple jabbed and have recently have had COVID, but now test positive, apart from solidarity with others and as a good example, is there any medical reason to carry on wearing masks or taking other precautions for the next month or so? Or is now the time for those of us in that situation to go out to restaurants and do all the other things we've been avoiding for so long? Thank you.
Thank you. It's a very good question, because I suspect that's a lot of the reason why once people have had their 3 jabs, they think they can do absolutely anything. So who would like to go to that? Helen, maybe? Oh, sorry, Steve. Steve has his hand up.
Well, Chris, I've had 3 jabs and I also had a recent BA2 infection. So I think it's really hard to just assume that your response to a vaccine or indeed to an infection on top of that is going to be the same for everybody. And I think this sort of speaks to what Ravi was saying before. We all make different responses to vaccines. Yes, we should be very well protected against severe disease, but we are seeing reinfections, we are seeing breakthroughs. So I do think that, especially whilst prevalence is high, then unfortunately, I don't think we can really justify, especially in high-risk situations, relaxing completely. And I think, we know full well how to prevent these infections. You could be reinfected. There was a case presented at the ECMID conference recently where someone was reinfected 20 days since their previous infection. So it's not uniform. And yes, the vast majority of people should be very well protected, but you can't say that for certain. So I would advise, caution, but we need to have a situation here where we're balancing individual risk against population risk, and population risk should be looked after by the government, really.
Helen.
I'd just like to add to that although your individual risk may be not of having severe disease or needing hospital care would be very low, you may still get it and you may still pass it to other people. So I think a lot about wearing masks is not about just protecting ourselves, but about our care for the people around us, particularly those whose immune systems don't work so well and may not have responded as well to the vaccines they have. So I personally am still avoiding crowded indoor unventilated spaces and wearing my masks where I can't avoid it. It's a bit dismal, isn't it? Because we'd all like it to be over, but it's not.
Quick response from Dipti.
Yeah, I just want to say that we don't really know about long-term effects here. So we've seen a lot of evidence, largely from the pre-vaccine era, that people have a high risk of diabetes, cardiovascular disease, stroke, kidney disease. And even 1 year down the line. Now, how much that is prevented by 3 doses of vaccine and, for a given variant is something we just don't know. And while we don't know that, I think we should assume that infection isn't harmless even for healthy people, because healthy people with mild infection have had all those complications a year later in the pre-vaccine era. We don't know how that changes yet.
Susan.
Thanks. I just wanted to add that in other areas of our life, we make sure that the environment is safe. We make sure we have safe environments in the workplace for people of all kinds to go into and feel that they're not going to get ill as a result of going to work. When we travel, whatever we travel by, car, bicycle, whatever, we have ways in which we make the environment safe so that people are less likely to be knocked off their bike, however they ride their bike, and less likely to be harmed if something happens to them in their car. So similarly with COVID, I think we have to keep stressing, and I know we have on Independent Sage stressed it a lot, that what we want is to create safe environments so that everybody can feel okay about going out to pubs and restaurants. There's absolutely no reason why we shouldn't be asking for safe air in public spaces. Recently in Belgium, there's been laws passed that public spaces need to meet a certain standard of air quality to keep everybody safe, just as we have certain standards for food quality and water quality. So I think we really need to get behind this in this country and push for a safe environment and not leave it all down to individuals and individual behaviours.
Thanks. Next question from Carol. I'd be grateful for any data or even your intuition on outcomes following repeat infections. Does it follow that our immune system's response makes us less likely to die from COVID if we survive our first brush with the virus? Raj? Not Raj, Ravi.
I thought we had a new participant.
Sorry.
So this is an interesting one. I think that Delta showed us that reinfection can be fatal. I think that in India, there certainly were, large numbers of people who had a previous infection who ended up dying with a variant that had, of course, had high infectivity, and then obviously it was a pathogenic variant. So I think it depends on the variant that you're challenged with. I think it's probably rarer if you're challenged with Omicron, of course, versus a prior infection. So that it's variant dependent. It's dependent on the time period that's elapsed because of waning, etc., and what's happened to you in that time period. So a number of different factors, and probably virus dose is something that we don't really talk about, but the amount of exposure you get and the route of exposure is probably important as well, although we haven't measured many of those things very, very accurately. So I wouldn't necessarily take a prior mild infection as guarantee that you will not get a severe infection.
Thank you. Okay, next question. What defines the end of the pandemic? What are objective endpoints that when we reach before we can go back to normal? Christina. Or Duncan, if he's still with us.
Duncan had to leave. I don't think there are. I don't think there is an end. I don't think there's a date that you can say, right, that's it. Particularly with, I'm sure there are experts on here who can talk about it, particularly when you have a virus that can go between animals and people, you have a situation where it could always come back. And in fact, we've had the first SARS pandemic epidemic back in the 2000s. There's no particular reason to think that you can say we're never going to have another COVID wave. What we can do is try and prevent waves being less, as destructive as they are being. I guess that's my opinion.
No one else on that. Steve.
I think Susan might have been first. Susan, do you want to?
Sorry, Susan.
Well, only a small point in that this word back to normal, I'm not the first person to have said this. It's been said thousands of times, but it can't be said enough, is that it was normal that got us into this situation to begin with. And we don't want to go back to normal. We want to learn the lessons of what happened, why it happened, and build a new resilient society, more resilient society, and really put together all the evidence as to what resilience means, not only from pandemics, but a host of other infectious and other diseases, and indeed other threats to society. So I just wanted to make that point about the word normal.
Thank you. Steve, did you have a quick?
Just very quick. I mean, I think I completely agree with Susan and with Christina to a great degree. I think we had a real setback today when we heard that the vaccine companies aren't going to be prepared to share their patent rights for the vaccines to other countries, because that's really going to slow things down. The definition of a pandemic is that it's occurring in explosive ways of infection in multiple countries across the planet. So the problem with that is that it's unpredictable. Our immunity is unpredictable. The virus is unpredictable at this point because of the scale of infection mainly. So until that starts to calm down and become predictable, which is where we might start to use terms like endemic and predictable, even though that might have seasonality with it and all that sort of thing, then we really can't say that we're beyond this pandemic phase. And so I think that a lot of the rhetoric that we're hearing at the moment is misleading and could ultimately cause more harm than it does any good.
Thanks, Steve. I've got two questions that are similar, which I'll just read out. Has anyone got any thoughts behind the rise of hepatitis cases? Could it be linked to COVID? UK cases are extremely high. We seem to have the highest figure of hepatitis. Is that a coincidence? And from a public health doctor, she says if there's reduced or little or no community testing available, how will we pick up links with new presentations like hepatitis cases? Many have recorded COVID-19 in the past few months. The link between COVID and this hepatitis needs exploring in conjunction with adenovirus 4.1F theories. But in the future, no one will know they've had COVID. So how will we identify that any strange new presentation is due to a past COVID infection? Any thoughts on that? Dipti.
Yeah, I mean, I think that's a huge concern. And for me, that's actually a major concern because we're still discovering new presentations of this virus. I mean, in terms of the surge we're seeing, yes, I mean, it's very clear that we're seeing large numbers in the UK, whether that's because surveillance is better or because the numbers are higher, I don't really know. Yes, 75% of those cases have been found to have adenovirus infection, but classically adenovirus isn't associated with this sort of presentation in healthy children. And, you know, I've heard a lot about, you know, this being related to lockdowns or, you know, mitigations or social distancing over time, but that still doesn't explain why children should have a different presentation, because even in normal times pre-pandemic, there were 3-year-olds who got this virus for the first time. It wasn't that 100% of children at age 1 and 2 were being infected. So why are we seeing a different presentation? And I think we cannot rule out COVID here. I mean, if you look at Israeli experts, they're telling us that in their, what they're seeing in hospital, the majority of children had, you know, recent prior infection, which is something that we haven't been able to assess. But what we are seeing, at least in our admissions, is that the positivity for the virus is 17%, which is 2 to 3 times higher than in the community. And I think that needs to be explained. I don't think we definitely know what it is, but it could potentially be an interaction between different viruses, possibly including COVID. And I think until we rule out either cause, we should be actually emphasizing mitigations and protections for children, because that's an age group that's, you know, under 5, unvaccinated and unprotected at this point in time.
Thanks very much. There is an interesting question on FP3 masks and clinically extremely vulnerable, but I think I'm going to carry that over till next week because it's a big issue and because we're at time. And I'll leave you with one thought for the day, which relates to what Steve has just said. Yesterday, the Director General of the World Health Organization made a plea to Pfizer and Moderna shareholders to share their technology and vaccines so that the world could be vaccinated, because in low-income countries, which is nearly 3 billion people, only 12% of people are vaccinated. And the shareholders, 75% of them in both countries or both companies, rejected it. That's the world we live in, profits before people. On that miserable note, we'll say thank you to everyone, all the support and participation from the public. Thanks for your questions. Huge thank you to Aris, Katrina, Ravi, Dan, and we'll look forward to seeing you all next week. Same time, same place. Stay safe, keep well. Bye.
Thanks, Anthony. Bye.